Dental ceramics. Ceramics. Materials composed of inorganic metal oxide compounds, including porcelain and similar ceramic materials that require baking at high temperature to fuse small particles together. Crown. An indirect restoration that covers all or part of the coronal tooth structure, extracoronal, and is composed of metal, ceramic, or a combination of the two. It can also cover an implant. Fixed bridge. A dental prosthesis that replaces one or more missing teeth and is cemented to adjacent natural teeth or implants. It is composed of the same materials as crowns. Inlay. An indirect restoration composed of ceramic, composite resin, or metal that is fitted to a cavity preparation that is within the crown of a tooth, intracoronal. Onlay. Restoration that is similar to an inlay but covers or replaces one or more cusps. Veneers. Thin layer of ceramic or composite resin that is bonded to the facial surface of teeth to improve their color, shape, size, or length. Glass-based ceramics. Ceramic materials with a silica glass matrix with or without fillers such as lucite or lithium disilicate. Non-glass-based ceramics. Crystalline-based ceramics without a glass matrix. All ceramic restoration. Ceramic restorations with no metal core. Porcelain. A tooth-colored ceramic material composed of crystals of feldspar, alumina, and silica that are used together at high temperatures to form a hard, uniform, glass-like material. Lithium disilicate ceramics. Glass-based ceramics with lithium disilicate fillers to enhance physical and mechanical properties, especially flexural strength. Zirconia. A non-glass polycrystalline ceramic that is the strongest ceramic used in dentistry. Flexural strength. Strength required to resist bending of the bar or ceramic material to its point of fracture. Fracture toughness. Material's ability to resist fracture from crack propagation. Sintering. Fusion of ceramic particles at their borders by heating them to the point that they just start to melt. Slip casting. Process whereby ceramic powder is mixed with a water-based liquid to form a mass or slip. The slip is pressed into a form and baked at high temperature. Heat pressing. Pressing molten ceramic material into a mold at high temperature and pressure. CAD/CAM. Computer-assisted design, computer-assisted machining that uses a scanning device to capture an image of the preparation and is integrated with computer software to design and a milling device to cut restorations from blocks of restorative dental material. Porcelain metal restoration. Restoration has a metal core over which porcelain is fused at high temperature, commonly referred to as porcelain fused to metal PFM or porcelain bonded to metal PBM. Amalgam and gold were main restorative materials until ceramics were introduced into dentistry over 100 years ago. Ceramics were first used for the fabrication of denture teeth, and then Charles Land introduced porcelain jacket crowns and inlays in the 1900s. Land's porcelain jacket crowns were very aesthetic, but the porcelains of the time were brittle and tended to crack when used in high-function areas of the mouth. In the late 1950s, porcelain was fused to a metal core to make aesthetic crowns much stronger. In Europe in the 1970s, the first computer-aided design, computer-aided manufacturing, CAD/CAM system was developed using ceramic blocks to produce inlays and onlays. In 1987, the first chairside CAD/CAM system, CEREC 1 Siemens Dental, was introduced. Also in the 1980s, the introduction of a castable glass-based ceramic launched numerous innovations in ceramic processing. Within the past 3 decades, all ceramic materials have been introduced that are much stronger than the original porcelains, and with some improvements in aesthetics. As a result, the use of all ceramic restorations has dramatically increased, while the use of less aesthetic porcelain fused to metal crowns has decreased. At present, ceramic materials are used for a variety of restorations, such as crowns, fixed bridges, inlays, onlays, and veneers. Selection of the type of material to be used depends in part on the extent of damage to the tooth. the stress that will be placed on the restoration, and the aesthetic requirements of the patient. By enhancing the ability to bond restorative materials to metal and to structure, advances in aesthetic materials and techniques have assisted the dental team in delivering the aesthetic results that patients demand. The dental team must keep current with the rapid changes that occur in materials and techniques. Good listening skills are needed to determine the type of aesthetic services the patient is requesting, so that the dental team and the patient are working in concert towards the same goal. Aesthetic materials must be carefully selected so that their properties are compatible with the patient's oral condition and occlusions. Dental hygienists and dental assistants must understand the properties of these materials, so that as an important member of the dental team, they can help the dentist to assess the performance of the restorations and alert the dentist when they perceive that a restoration may be failing. The dental auxiliary needs to be familiar with the physical properties of materials so that they do not damage the restorations during routine oral hygiene coronial polishing and preventive procedures. Dental assistants need to know the handling characteristics of aesthetic materials so that they can either assist the dentist in their placement or perform steps in their placement as permitted by state dental practice acts. In addition, they will be called on to assist in shape taking for the restorations and steps in CAD/CAM procedures if used in the office. This chapter also describes the physical and mechanical properties, processing methods, including computer-assisted design, computer-assisted machining, CAD/CAM technology, clinical applications, attributes, and shortcomings of aesthetic ceramic materials. The rationale for the selection of ceramic materials for various clinical applications is presented. The principles for adjusting, finishing, polishing, and cementation of ceramic restorations are reviewed. Guidelines for selection of the shade of these materials to obtain satisfactory cosmetic results are also discussed. Dental ceramics. The general term ceramics is used to describe porcelain and a variety of materials that are similar in appearance to porcelain, but vary in their composition, mode of fabrication, and physical and mechanical properties. Dental ceramics can be classified in a variety of ways based on their composition, processing method, fusing temperature, microstructure, translucency, fracture resistance, and abrasiveness. Glass and non-glass ceramics. To simplify the understanding of dental ceramics, they will be classified in two broad categories according to their composition: glass-based and non-glass-based materials. Glass-based ceramics have silica as the main component and have a glassy matrix. They include feldspathic porcelains, Lucy reinforced ceramics, and lithium disilicate ceramics. They are more aesthetic than the non-glass-based ceramics. Non-glass-based ceramics are crystalline in nature and composed of simple or complex oxides with no glossy matrix. They include alumina and zirconia. They are the strongest of the ceramics. Feldspathic porcelain is the oldest of the porcelains used in dentistry. It was introduced in the early 1900s. It is the most aesthetic but the weakest of the ceramic materials used. Glass-based ceramics are most aesthetic and mimic the optical properties of enamel and dentin. However, they have low values of flexural strength. The higher the crystalline component added to the glass matrix, the greater is the strength. Non-glass crystalline ceramics have the highest flexural strength, but are not as aesthetic and are more opaque. The strongest of these materials is zirconia, but it is commonly veneered with porcelain to use where aesthetics is important. The summary of the CAD/CAM steps for producing a restoration. Complete the preparation using principles for all ceramic restorations. Use the optical scanner to obtain an image of the preparation lined up with the path of insertion of the restoration. Some scanners require coating the preparation with a powder to enhance scanning accuracy. Use the computer software to design the restoration. Mark margins and establish restoration contours on the computer screen. Use the software to simulate occlusal excursions. Select block of the correct shade of the ceramic material and place it in the milling machine. Program the milling machine for the material being used and activate the machine. If the milled restoration was in the green or soft state, it will need to be fired to complete the sintering process. Characterization with surface stains can be accomplished while applying the overglaze. Tried in the completed restoration. Cement the restoration after etching internally and applying silane. Zirconia should not be etched or silanated. It has special primers. Check and adjust the occlusion as needed after cementation. Handle veneers carefully. They are very fragile until bonded. Ultrasonic scalers, if improperly applied, can chip and crave margins of aesthetic materials. Generation of heat during adjustments. Finishing and polishing of ceramics can cause damage that may progress to fracture of the restoration. Use rotary instruments at low speed with water spray and light pressure. Avoid acid etchants and acidic fluorides on ceramic restorations. They will roughen the surface of the ceramic. Steps for shade taking. The following steps should be used when taking the shade of teeth. Use natural light when possible. Use cheek retractors for an unobstructed view of the teeth. Raise the patient to view the teeth at eye level to use the color-sensitive part of the retina. Wet the shade tab and the teeth to remove surface texture differences. Place the shade tab in the same plane as the teeth, not in front or behind. View the teeth and tab for no more than 5 seconds at a time. Rest the eyes between viewings by staring at a neutral color gray. Pick the best 3 shades tabs quickly. With the input of patient, doctor, and assistant, select the best of the 3. If possible, use photography to aid the tab technician. Place the shade tab next to the teeth in the photo. Note tooth factors the lab will need to characterize. The summary. A wide variety of tooth-colored aesthetic materials are available to the dental team to use to restore a patient's dentition. Patients demand high-quality restorations with a close match to their existing teeth, or in some cases, they demand restorations that produce a lighter, youthful smile. Newer ceramic materials have broadened the choices the clinicians have for aesthetic restorations, and CAD and CAM technology is providing new avenues for the dental team to provide aesthetic dentistry, with the potential for making many procedures faster and easier on the patients. It is important that all members of the dental characteristics, physical properties, and potential shortcomings of these materials. Before working in the patient's mouth, it is wise to review the dental chart section of the patient's record and perform a brief oral inspection to protect the presence of the aesthetic restorations. Drying the teeth with an air syringe can help reveal some of the materials because they may have a different luster than the enamel, or margins may be more readily visible once the saliva has been removed. The selection and use of proper polishing and scaling devices are an important consideration for the hygienist and the chairside assistant when working around these restorations. Ultrasonic scalers have the potential to chip or crave the margins of all ceramic or composite restorations. When applying topical fluoride, it is important to keep in mind that the surfaces of these aesthetic restorations can be affected by the use of acidulated fluoride solutions and gels. The use of these products can dull the surface of the restoration and change the aesthetic effect of the original restoration, making for an unhappy patient. Neutral sodium fluoride products of fluoride varnish can be used as alternatives. Certain abrasives used for coronal polishing can also adversely affect the surface luster of composites and porcelain. The radiographic appearance may be different for each various aesthetic restorative material. And new aesthetic materials are adopted in the practice. It is important to become familiar with their handling characteristics, physical properties, uses, and precautions.